We talked a lot about nurses this morning, and we talked about it yesterday as well, and I just wanted to sort of clarify things, because I know there's many healthcare workers in the room, but some of you are not. And so I just wanted to clear up a few things. I'm a nurse, but I'm a registered practical nurse. But in the province of Ontario, there are two categories of nurses, RNs and RPNs. And so there seems to be sort of some confusion. When the ministry, for instance, would talk about nurses, they're talking about both levels of caregivers. We're governed by the same legislation, and we're registered by the same college. So we certainly work together. I'm an RPN, as I've said. I'm not a dumbed-down version of an RN. I'm an independent practitioner. And I do work with a variety of people on a fantastic healthcare team. I work with lab technicians and ward clerks and housekeepers and cooks and doctors and PSWs and CSR technicians and so many others. And we work together. We work very cohesively, and that also includes, of course, with our RNs. And we work very cohesively. We provide incredible care, incredible quality of care for the patients and the people that we serve in Ontario. Thanks.
Thank you very much for your presentations. The emergency room doctor, is it Dr. Hawes? Is that correct? Dawes. Something else that I don't think you mentioned, but I think should be considered too, is the elderly especially. I know my mother, for instance, she has to get so sick before I can finally talk her into going to an emergency room, because she knows what she's in for. Hours and hours and hours and hours on that gurney. She has arthritis. The idea of being on that gurney at all terrifies her. So I wonder how much sicker people are when you see them than they would be if it wasn't for all the waiting. And the other thing is I didn't realize that the walking wounded, as you call them, or the people with the sniffles and the cough, and a lot of those are because they don't have a family doctor, at least in our area, but I thought they were the ones that were plugging up the system. And I'm really happy to hear that it's the lack of beds. I think that's a piece of information we all needed to get. Thank you.
Those are very good comments. One of the things I fear when you close a rural emergency department is that problem you mentioned of people being reluctant to go are going to be even more reluctant to get in the car and travel to St. Catharines or Welland or wherever, rather than go to their own local hospital. And the tendency seems to be that the waiting times in the larger hospitals are much worse than they are in the smaller hospitals. So all of these things have to be factored in by the people who are planning whether to close these emergency departments.
But I just want to point out, you pointed out that you're moving services out of hospitals into the community. Money is now following those services. The CCACs went from 44 to 14, huge Lynn area. There are CCACs that go from Campbellford to Scarborough and up to Haliburton. And that's one CCAC, one employer. So you can imagine how they stretch services. So the money is not falling to the community, and our patients are going to suffer.
I wonder if you can clarify a little better for me the issue of availability of beds. Are you saying that there is no physical room and no physical bed available, or are you saying that in some cases in the hospital, for example, there's an area where there is room, there is a bed, but it's sectioned off and you can't use it? Because I know of at least two different scenarios, even in Sault Ste. Marie, where there's a room, there's a bed, but they've decided to close that part off. So can you clarify that for me if you can?
Well, the hospitals where I work have closed beds. I mean, and you're right. The physical space is there. But it's not being used. It's not being used for a variety of reasons, some of which are what Kim talked about. There's no nurses available to work there. There may be no money available. Whenever you open a bed, there are a whole series of costs associated with it. Nursing staff, cleaning staff, more patients in the hospital, more laboratory services are needed, more imaging services are needed, etc., etc. So that if the hospitals are being squeezed, they don't have the money available to open those beds. And as Kim showed also, even if you've got some money, you may not have the nurses to hire to be able to run those beds.
you make me cry. I had to sit here and wipe my tears because I'm from a small community. And I'm just going to make a statement. Our small hospital, we have a friend that's been in there for, since October. He's got a bowel problem, and there's not much they can do for him. Anyways, one night they sent him home because they needed that bed. 12 o'clock at night, the ambulance was at his home and rushed him back in, and we almost lost him.
I've watched our LHIN pour a lot of resources and finances into 2 large centers within our LHIN. Both of them fall about 35 minutes away from our community. Is there a magic number or distance within which they can close an emergency department? Like, does there have to be a certain distance for people to travel? Does everybody understand that question?
The rural and northern healthcare framework document, which is in your package, uses 40 kilometers as a number. I have argued strongly that you cannot use a number. It depends so much on everything else, whether it's population densities and weather conditions and traffic conditions and the type of occupation that people work at. I mean, personally, I don't believe there is a correct number.
Due to the layoffs in the 80s and 90s, we had a huge number of healthcare professionals who left the profession. So you can open as many beds as you like, but when people go to hospitals, they need to be seen by physicians, they need to be looked after by a whole team of healthcare professionals. We do not have those healthcare professionals waiting in line to staff those beds. So when an ICU cannot admit, often it's not, they've got a bed. They do not have the staff to look after those patients, because every time you cut a direct healthcare provider at the bedside, you lose 2,000 hours of direct patient care. So right away, that's the problem. You can open beds, you have no people to look after the people in those beds who need the complex care from a whole gamut of healthcare professionals.
Patients that are coming to us looking for information is around when a doctor's order is given, there seems to be an overriding of this doctor's order, either via CCAC, trumping it out, saying, well, we don't have the resources, therefore, you know, they're going to have to pay for the services in order to be able to meet what the doctor's order. I have 3 other issues. I won't take the time up to go through them now, but I would like to talk with you afterwards, and I thank you very much for your presentation.
That the hospital beds and payment for them has changed over the years simply because of the reduction in number of physicians. Secondly, the medical profession is sort of, in this area, is working their way out of jobs, in that the surgical, the drugs, the treatment modalities have by themselves reduced the average length of stay, required stay for patients with surgical and medical problems. The big problem actually arises from the fact that because there is a major reduction in the availability of physicians practicing in the smaller hospitals, this has driven the percentage of the population not being able to access a medical practitioner, a doctor, family doctor, as we used to call them. So that now there's a real problem for this government and for us is that the government has not recognized, in the terms of emergency services, that a major percentage of visits to the emergency care are in lieu of being able to see a doctor of their own. So, but that is a fact of life. Until the medical numbers are increased, we're always going to have this concern about people paying for the cost of running a medical emergency department. So there's cause and effect and operates normally.